The first thing we have to say is that it's primarily a disease of the older patients. The median age is approximately 70 years at the time of diagnosis. By definition, it's a quite challenging population of patients with cancer. And the majority of these patients will in fact receive 1 or 2 lines of therapy. Some of these patients will be frail or very frail and was very difficult to treat patients. But still, we for some years we had quite good regimens for these patients. Some based on bortezomib, some based on lenalidomide. So if you look at guidelines, you will see that the combination of bortezomib, melphalan, prednisone has been established 10 years ago as a standard of care. The same is true for lenalidomide in combination with low-dose dexamethasone. And so these were the two, I would say, usual standards of care for these patients. So recently we got new regimens, and I would say, as expected, the next regimen is the combination of bortezomib and lenalidomide and dexamethasone, so which is called VRD or RVD. The good news is that this regimen has been approved by European Medicine Agency recently for transplant ineligible patients. So this can be used, and I think in many European countries you will see VRD patients. So this regimen can be modified to mitigate, to improve tolerance too, so to mitigate toxicity, I would say. So you may have some kind of VRD light regimen. So this is basically a good regimen. Also because the combination of a PI and an IMiD has been successful in many different studies. So this is the first step, and I would say this is the step for today. So the next step is what we call daratumumab combination regimens, basically. So CD38 antibodies are key drugs in myeloma. So the drugs have been approved some years ago in relapsed patients, and the daratumumab and other CD38 antibodies have been moved up to first line. So we have ongoing studies in first line, but we have 2 studies which have been fully published, and regimens have been approved, at least one of them. The first one is daratumumab in combination with VMP, which has been approved. The other one is daratumumab in combination with lenalidomide and dexamethasone. But if your question is for what should we do for next week, I would say for next week you could stick to let's say the old regimens, the VMP or Lendex, or you may want to go with the VRD or some kind of VRD light, which is probably, what we know is that if you look at the French market, for example, we have already approximately 30% of patients, or maybe 25-30% of patients receiving VRD, which means that we do consider that these patients are relatively fit and may receive this kind of combined regimen.